Alrighty guys, we might get started. So hopefully you can see my screen, which just has GIT revision. My name's Izzy. Feel free to interrupt at any time if you have any questions. And I'm presenting with Charlotte, so you can either, probably easier if you do questions into the chat, and then we'll go from there. So pretty much the aim is just to go through general GIT revision, anatomy, physiology, a few of the clinical conditions, pharmacology. We've got a bunch of questions at the end, and we'll see how much we get through, but they'll be there for you guys for revision if you'd like those. So yeah, obviously we're just kind of trying to give you the information that came up on a lot of practice exams and comes up in like third year and seems pretty important. All right, so to start off with, just general surface anatomy. In the GIT, it's really important that this is pretty clear in your mind for OSCEs, and also if you can kind of visualize what structures are underneath in each area, that's going to really help you work out different patterns of pain when you have like clinical scenarios in written exams as well. And just a reminder that the vertical lines are mid-clavicular and then the horizontal lines are your subcostal and transtubercular. So with the abdominal wall, the layers, so superficial to deep, you've got the skin and then the subcutaneous fat. Then you've got your Camper's fascia, which is on the outside. Think of like a camper, you camp outside. And then you've got your scarpas, which is more internal, I guess. And the deep one, sorry, and it's more membranous. And then you've got your muscular layers with their respective fascia. And then you've got the extraperitoneal fat, and then the parietal peritoneum, and your abdominal cavity, which we'll go into more details later. But yeah, I suppose the big ones are the muscles, which I'll touch on more, and the fascia from the layers there. And there's just a diagram kind of putting it together with your layers, the aponeurosis, and the muscles. So in terms of the muscles, it's kind of similar to the thoracic cage. You've got your external obliques and they run inferior medially. So if you kind of imagine putting your hands in your front pocket, that's the direction they run. And then you've got your internal oblique, which is the opposite. So they run inferior medially. And then you've got your transverse abdominis, which just run horizontally. And then in the center, you've got your rectus abdominis and your pyramidalis, but it's a bit of a myth, I think. And sorry, the important landmarks is your rectus sheath. So that's formed by the aponeurosis from the three flat muscles on the sides that cover the rectus abdominis muscle in the middle. And about 3/4 of the way down the sheath is this arcuate line, and it's like a transition point, which above the line, the rectus sheath is anterior and posterior to the rectus muscle, and below it, all the aponeurosis of the sheath goes anterior to the rectus muscle, and it's only the transversalis fascia posterior. And also at that line, which is here in the diagram, the inferior epigastric vessels perforate the rectus, which are a good landmark for your hernias, which we'll talk about. And other landmarks is your umbilical folds. So in this diagram here, imagine like you're the stomach and you're looking at the front abdominal wall. So it's from the inside. You can see that you've got these, the important ones are the medial umbilical fold, which is your obliterated fetal umbilical artery. And that kind of is important for portal hypertension, and it can cause, it's like the pathophysiology basically behind caput medusae. And then the lateral fold is your inferior epigastric vessels, which is a landmark for inguinal hernias. In terms of innervation to the abdominal wall, an important one is that T10 is the umbilicus, and it kind of follows a dermatomal distribution. And then from there, you can kind of work out the rest, but it's T7 to L1. And often as part of multiple choice, one of the options will be shingles, or often they use shingles as an example just to make you think outside the box, because it's pain on the stomach, but it's pain that follows a dermatomal pattern, and often there's like an associated rash and itch. So that's shingles. It's not actually a true abdominal condition. now more anatomy. So with the diaphragm, there's a few openings. So at T8, that's where the IVC and the phrenic nerve go through from the thorax to the abdomen. T10 is the esophageal hiatus, which is where the esophagus goes through, and the vagus nerve. So I just remember that the vagus nerve is really important for like your digestive parasympathetic innervation. So that's why it travels through there with the esophagus. And then the aortic hiatus, which is where the descending aorta passes through with the azygous vein and thoracic duct. And the more inferior they are, the more posterior they are, which you can see in this diagram. And the way I remember it is vena cava, 8 letters, T8, esophagus, 10 letters, T10, aortic hiatus, 12 letters, T12. All right, then we go on to the peritoneum. So it's a continuous membrane that lines the abdominal cavity and also covers the organs and viscera. So very similar to the pleura of the lungs, ultimately. There are 2 layers continuous with each other. Parietal is more superficial, so it's lining the inner surface of the abdominal wall, and it's somatically innervated, so that's well localized. And then the visceral peritoneum is deeper. It lines the organs, and it's autonomically innervated, so same as the underlying organs, which is poorly localized, and it refers to the dermatomes of embryological origin. So for all things in the gut tube, like the stomach and things, it all kind of centralizes, and then other organs might be a bit more on one side, where the pain goes to. And then the peritoneal cavity is kind of the space between, it's a potential space, so normally there should only be a little bit of lubricating fluid in there, but it's the space between the 2 layers of peritoneum. Why it's important to understand, just because the radiation of pain is different between intra and retroperitoneal organs, where fluid accumulates, spread of infection, surgical access and intervention. It kind of helps you understand those concepts. And also when there's damage to the peritoneum, so like during an operation they cut through it, when it heals it can form adhesions, which can lead to other pathologies like bowel obstructions.
Another really good example of the difference between the parietal and visceral pain and stuff is like appendicitis. I'm sure they drill into you that starts like central pain and then goes to the right iliac fossa. And that's because it's starting as your visceral pain, which is like vague central, because it's an abdominal part of your digestive tract. And then when the inflammation increases, it irritates the parietal peritoneum, leading to this specific pain where it's located, if that helps you. I don't know.
Perfect. And then the mesentery is a double fold of peritoneum. So ventral mesentery is just in the foregut, and basically the main examples is your lesser omentum, which is from the lesser curvature of the stomach, and your hepatoduodenal ligament, which is kind of like the free border of the lesser curvature, and that's also called the epiploic foramen or the foramen of Winslow, and that contains the portal triad. And the clinical relevance of that is that it's kind of like used in surgery, like it's manipulated, this phenomenon, the mesentery, because you can clamp the portal triad to stop hepatic bleeding. And then there's also dorsal mesentery, which is throughout the whole gut tube, and that includes your greater omentum from the greater curvature, so that kind of makes sense. And it's kind of like this massive fatty structure that can migrate towards infection. And there's also mesentery that attaches the viscera to the posterior abdominal wall and between abdominal organs. And basically inside the mesentery, that's where you find like your SMA, your IMA, and also lymphatics and nerves. And then this is kind of just a picture putting it together. So you can see the lesser omentum here, the greater omentum there, and the organs, which would then be surrounded by their peritoneum, and then where it comes together, you get the mesentery. Intraperitoneal versus retroperitoneal. So intraperitoneal is an organ that's enveloped by visceral peritoneum anteriorly and posteriorly, and then retroperitoneal is structures that develop behind the peritoneum. So they only have an anterior surface covered by parietal peritoneum. And then secondary retroperitoneal is structures that were once intraperitoneal, which then become retroperitoneal. And so retroperitoneal structures refer pain to the back. So pancreas and aorta are kind of like the big ones. Yeah. How I remember it, there's like an acronym, but I just think if it's mobile, it has a mesentery. If it's fixed or really posterior, then it's probably, and it has a mesentery, then it's intraperitoneal. If it's fixed and very posterior, then it's retroperitoneal, and the gut tube alternates between being intraperitoneal and secondary retroperitoneal. So esophagus is retroperitoneal, stomach and first part of duodenum intraperitoneal, second, third, fourth part of duodenum retroperitoneal, small intestines intraperitoneal, etc. And then important spaces from the foldings is the lowest point in the peritoneal cavity in a standing person. So is where the fluid is going to accumulate in like an infection, or if they've got ascites or something like that. So in males, there's only one. So it's the rectovesical pouch. And in females, they've got two pouches because of the uterus. And so it's the more posterior one again. So it's the rectouterine pouch, or the pouch of Douglas, that's deeper. And just another fun fact is that the peritoneal cavity in males is closed, whereas in women it's open, and it's continuous with the uterine tubes. So potential passageway for infection spread. Then if the person's lying down, where's the fluid going to accumulate? So it can also still accumulate in like the rectouterine pouch, but the hepatorenal pouch is the other place, or it's also called Morrison's pouch. Then hernias. So definition is that it's a protrusion of viscera or peritoneum through an opening, which can be normal or abnormal in the body wall to which it belongs. So it's stuff getting somewhere abnormally through an opening, basically. And there's different classifications. The main ones for second year is just to know about the different locations they occur at, but they can also talk about reducible, which is like, can it go back in? Or if it's incarcerated or strangulated, so if it's stuck and the blood supply is cutting off. And the common ones are the direct inguinal hernia and indirect inguinal hernia and the femoral hernia. And these are kind of other ones that might be good just to be able to rule out in multiple choice, but you're probably not going to be tested on them. So in terms of inguinal anatomy, the inguinal ligament is going to run from the acis to the pubic tubercle, and it forms the floor of the inguinal canal. And then the inguinal canal itself just runs above the medial half of the inguinal ligament. So the deep ring is the midpoint of the inguinal ligament, and then the superficial ring occurs just superior and medially to the pubic tubercle. And in males, it's bigger because it transmits the spermatocord and the associated nerves, arteries, veins, and muscle, which I'm sure you guys are aware of. And then Hesselbach's triangle, it's basically just, in all people, it's just like an anatomically weak part of the inguinal canal. So it's this area here, and it just has transversalis fascia. And so, yeah, that's pretty much it. And it's important to remember that in terms of landmarks, it's inferior to the epigastric vessels, whereas the deep ring of the inguinal canal is lateral. Yeah. And just other landmarks is that the mid-inguinal point is the point between the pubic symphysis and the acis, and that's where you find the femoral artery compared to the midpoint of the inguinal ligament, which is the deep inguinal ring. So it's kind of just a tongue twister. So in terms of hernias, indirect goes through the deep inguinal ring, and there's no real hole. It's just kind of following the pathway of the spermatic fascia. And so the hernia will be felt lateral to the inferior epigastric vessels. And it's the most common type of hernia, especially in young males, which have a patent processus vaginalis. And then direct hernia, I think of it as the hernia goes directly through the abdo wall, which is usually through Hesselbach's triangle. And it's more likely in people who are older or pregnancy, they have like additional factors that make it weaker. And the kind of buzzwordy thing is that it's medial to the inferior epigastric vessels. Femoral anatomy and hernia. So the femoral canal runs beneath the inguinal ligament, and there's the structures. So you've got the nerve, artery, vein, the empty space, which is the canal, and lymphatics also runs through there. And then you can also see the femoral sheath kind of encompasses everything except the nerve. In terms of femoral hernias, it mainly occurs in females because they have a wider pelvis, and therefore they're going to have a bigger femoral canal. And these hernias are prone to strangulation, so they can be complicated. Yeah, and the hernia will be inferior and lateral to the pubic tubercle compared to being medial and superior if it was a inguinal hernia.
And just as a quick little revision question, because this comes up a lot. So say if you've got like, the question will be like, a young male presents with a lump around in the inguinal area. What hernia is this most likely to be? If you can either say it or just put it in the chat. And if it helps, it's that it's going through the lateral to the inferior epigastric vessels. Yeah, so indirect. So it's always, if it's a young person, it's more likely to be indirect because it's more likely an anatomical defect. And that's going to be lateral to the inferior epigastric vessels, where it goes through the ring. And then if it's a direct hernia, it's more likely to be an old person or someone who's had some trauma or surgery because there's weakness in the wall. Just as little buzzwordy things. And if you have any questions while we're going, just put them in the chat if you don't want to ask them on the thing. And we can try to answer them. No going, please.
Perfect, sounds good. All right, so moving on to the gut. You've got the foregut, midgut, hindgut. So the first bit is esophagus to the second part of the duodenum, and that's supplied by the celiac trunk, which comes off at T12. Then the innervation is it refers to the epigastrium region, so T7 to T10. And then midgut is your second part of the duodenum to the splenic flexure, just like around here. And then supplied by the SMA, which comes off at L1. And then innervation kind of refers to the umbilical area, so T10 to T12. And then hindgut is the last section, so from the splenic flexure to the dentate pectinate line. And that is supplied by the IMA and innervation refers to the L1 pre-pubic area. So that's just kind of like a general overview. And important is to remember the transition zones. So the cap of the duodenum, and then, yeah, sometimes it's referred to as like the last third of the transverse colon or the splenic flexure, which is also where the vagus nerve transitions to being the parasympathetic supply to the pelvic spine. So surface anatomy, we talked a little bit about before, but again, it's super important if you can try and remember, like if there's pain in the right upper quadrant, just immediately think, okay, what's there? So is it gallstones like the gallbladder, or is it something liver related, hepatitis and abscess? Epigastrium, you're thinking stomach, so like peptic ulcer, esophagus, or pancreas, pancreatitis. Left upper quadrant is like your spleen, and if it's on the flanks, then it's really going to be your kidneys or ureters. Umbilical, early appendicitis or aorta, and then, but that's more likely going to refer to the back. And then right iliac is going to be like appendix. And also just another point is to remember that cardiac pain can sometimes refer to the stomach, especially in women or elderly people or diabetics. And like genitourinary things can also be, especially in the lower part of the stomach, can also refer pain there. So like testicular torsion, ovarian torsion, ovarian cyst, sorry, and yeah, urinary retention and things like that. All right, so quick overview of the arterial supply. I really find that if I can kind of visualize a diagram, it makes it way easier. I don't really have to remember much. So your celiac trunk is coming off at T12, as I mentioned, supplying the foregut. SMA coming off at L1, supplying the small intestines and the ascending and transverse colon. And then coming off at L3 is your IMA, supplying the rest of your hindgut. In a little bit more detail, the celiac trunk branches into the common hepatic and the splenic artery, and also the left gastric artery. And then from the common hepatic, you get your gastroduodenal artery. And the kind of clinical relevance of that is that it can, if you have a duodenal ulcer, this can perforate this artery and cause bleeding. And the splenic artery can be perforated in a gastric ulcer. And then for the midgut, the SMA, there's different branches, jejunal, ileal, And yeah, I don't think there's that important, but what is important that you kind of form this marginal artery that runs around the edge. And especially where there's the transition from the IMA to the SMA, that's kind of a point where it's the first to go if there's a reduction in blood flow due to like hypovolemia or a clot or something like that. But it also means that if the SMA is affected, then the IMA might be able to compensate a little bit. And again, there's more specific smaller branches, which pretty much just relate exactly to where they're supplying. So it's pretty intuitive. In terms of the venous system, the GIT is special in that it has the portal system. So it's not just draining straight back to the heart via the systemic venous system. It's got the portal system, and that's basically because all the blood in the GIT is really nutrient rich, and so it wants to take the nutrient blood to the liver, which can synthesize and make heaps of products that your body needs. And so the main vessels are the superior mesenteric vein and the splenic vein, and they form the portal vein that then enters the liver. And also there's the inferior mesenteric vein, which usually joins with the splenic vein on the way to the liver. And so if there's like an issue with the liver and this is blocked, the blood backs up. So it backs up to the spleen, giving you splenomegaly. It backs up down to your anus, giving you like hemorrhoids. And so that's kind of like the idea behind portal hypertension. And so it also backs up to the esophagus, giving you esophageal varices. So all those transition points between systemic circulation and portal circulation is where you kind of get the pathologies related to portal hypertension. Then a quick overview of the nerves. So the autonomic nervous system, all about rest and digest, is the parasympathetics. That's literally what I just come back to, whereas sympathetics is fight or flight. So parasympathetics, your main ones are your vagus nerve, and as I mentioned earlier, that's supplying the foregut and the midgut. And then you also have your pelvic splanchnic, which is supplying your hindgut, and I just remember P and P. And then your sympathetics is all about your splanchnics, your other ones, so the S sympathetics, and they're using the neurotransmitter noradrenaline acting on adrenoreceptors, whereas parasympathetic nerves are using acetylcholine acting on muscarinic receptors. And there is more detail on that, but that's the main gist. And then your gut also has an enteric nervous system. And so there's two forms of it, or there's two plexuses. So there's the myenteric plexus, which controls or has impact on your muscles. So I just remember my is really always got to do with muscles. And so that's located between the two muscular layers in the gut. And it controls motility and sphincter constriction. And then there's also a submucosal layer which controls the glands, and that's located in the submucosal connective tissue, which is where the glands are located. So it's pretty intuitive again, controlling secretion, absorption, and also the blood vessels in that area. And again, excitatory is acetylcholine, like the parasympathetic nervous system, whereas inhibitory is nitric oxide, and dopamine, which is smooth muscle relaxation. And it can be modulated by the autonomic nervous system and central nervous system, but it can also act independently, just kind of like when there's food in there, it will respond to that stimulus. Then you've got your sphincters, so controlling the passage of flow of food and also preventing backflow. And normally they're constantly constricted. The smooth muscle ones, so the smooth muscle ones are kind of all the ones inside you, and then the skeletal are at either end, over which you have voluntary control, but the smooth muscle ones are involuntary. And so sympathetic innervation causes contraction of them, and so the sphincters close, whereas parasympathetic, rest and digest, and the myenteric, their relaxation, sphincters open, want the food to go through. All right, so going to break it down into kind of like the different organs, I suppose, starting with the mouth and salivation. The big three kind of intrinsic salivary glands, are your parotid, which is the largest one, and kind of buzzwords, if they say they have a large parotid on examination, is you're thinking kind of chronic alcoholism and also mumps, mandibular gland and also sublingual. Another thing that they test you on is more later in head and neck anatomy, but is where these glands kind of, where the ducts enter in the mouth, but that's not really relevant for this. And then intrinsic, you have heaps of, like hundreds of other small salivary glands. What is saliva? Mostly water with a few other things, including salivary amylase, which starts the digestion process right from the start. And the most potent stimulus to produce saliva is nausea, because it's going to protect your mouth from the acidic gastric contents. And also saliva is the lowest during sleep, and it's usually parasympathetic innervation. And the clinical things related to it is botulism, excess salivation. It doesn't really come up, but like if you
honestly
kind of
don't worry about it.
No, but both of these, if you just go with it, like there's too much parasympathetic, so you want to do the opposite, muscarinic antagonist. Yeah. And insufficient, you want to increase the muscarinic effect. Esophagus, so that's a muscular tube that's going to move food bolus to the stomach. The circular muscles, so I talked about earlier that there's two layers of muscles, the circular layer on the outside and the longitudinal layer, the circular layer on the inside and the longitudinal layer on the outside. And the circular muscle constricts superior to the bolus and the longitudinal shortens. So that mechanism just pushes the food down. And anatomy starts at C6, at the cricoid cartilage, then goes through the hiatus at T10, and enters the stomach at T11. And the constrictions, so you've got your upper esophageal sphincter at the top, and then where the kind of arch of the aorta and the left main bronchus pass, that causes an indentation, so that's the thoracic constriction. And then there's also when it goes through the hiatus. And the esophagus is a transitional area, so at the top you've got skeletal muscle, and then it kind of transitions to being smooth muscle by the bottom of the esophagus, and also the venous system, as I mentioned earlier, it also transitions. So the top, it's systemic circulation, and then whereas at the bottom it's inferiorly, it's the portal system. Clinical relevant conditions, so GORD, which is reflux, and that's when your lower esophageal sphincter doesn't work properly, and so the acidic contents of the stomach kind of enters the lower part of the esophagus, also called heartburn, and it's worse when you're lying down, the effect of gravity, and also spicy food, anything that's going to irritate and create more acid in the stomach. You also got hiatal hernias, so sliding is just like if you imagine you held the esophagus and yanked it up, that's what happens, you're just pulling the esophagus through. And then paraesophageal hernia, which is when the junction is still underneath, so it's not underneath the diaphragm, but you kind of get this part of the fundus of the stomach that herniates through the diaphragm. And then with Barrett's esophagus, that's kind of the next step. So as a consequence of acid reflux, which can be caused by GORD or hiatal hernia, the acidic contents causes the cell lining of the esophagus to change. So it changes from the stratified squamous to simple columnar. So it becomes more like the intestines, and more glandular and goblet cells. And this does mean that the person is more susceptible to esophageal cancer. Then other things is vomiting blood, basically. And so some of the causes, if it's bright blood, then you're thinking it's like an esophageal cause, really. So it can be varices that have ruptured, caused by like portal hypertension, or it can be a Mallory-Weiss tear, which is caused by excess vomiting, like after a alcoholic binge or something. Esophageal cancer, which is also associated with dysphagia, so difficulty swallowing. And if they have a bit of blood, you might think esophageal cancer. And if the blood that they're vomiting is darker, then you're thinking that it's been partially digested, and so the pathology is going to be further down the gastrointestinal tract, so something like a peptic ulcer disease or gastritis. And then achalasia is when the lower esophageal sphincter doesn't relax properly, and so you get a dilation there.
And this stuff is important in like your GIT systems review, when you say like, have you had any vomiting, and then you follow it up with, has there been any blood in your vomit? And then if it's yes, you follow that up with, is it a small amount, a big amount, what color is it? Because that gives you clue, like you kind of just ask those questions blindly. But realistically, it's giving you clues. So if it's darker brown, then it's more likely further down the GIT tract because it's been digested. If it's bright, it's more likely higher up or a bigger bleed kind of thing.
All right, then the stomach. So in terms of the anatomy, you've got like the different parts, the cardia, which is like near the heart, fundus, the body, and then the pyloric antrum. So smooth the layers of the muscles. So you've got your outer longitudinal, inner circular, and the innermost oblique. So the stomach has an extra layer of muscle, and that's because it has an extra function, which is to churn the food compared to just passing it through the tubes. Then it's also on the inside of the stomach, you've got rugae, which are like folds of mucosa that increase the surface area. So that's going to increase the ability to absorb. And you've also just got your lesser curvature and the greater curvature where the omentum go from. And the lining of the stomach has protective mechanisms against gastric acid, which is basically bicarbonate-rich mucus, tight junctions, and the cells are rapidly and regularly replaced. Then, like if you go into a bit more detail, like the microanatomy, I suppose, you have pits, and that's where the cells that secrete digestive enzymes are located, and also the mucus. So there's heaps of different cells. They all are kind of important. So you've got mucus cells secreting mucus and bicarbonate, parietal cells secreting gastric acid, and also intrinsic factor, which is essential for vitamin B12 absorption, and then enterochromaffin-like cells, which are for histamine, chief cells, pepsinogen, and gastric lipase. So I've highlighted the really, really important ones, but they're all kind of important. And yeah, the aim of the function of the stomach is to convert your bolus into a mixture called chyme. Gastric acid, so it's an acidic environment because it kills pathogens, and it also is required for the activation of pepsinogen to pepsin, and can also help break down cellulose in plants. And this acidic environment is basically thanks to the parietal cells. And so hydrogen ions are pumped against their concentration gradient by a proton pump down here. And basically it also, as part of this, there's a bicarbonate alkaline tide in your blood after like eating. And another important factor is that you can see this is a parietal cell. It's kind of a dodgy image, sorry guys. But there's a lot of different receptors, but downstream, basically the aim is just to get more proton pumps. So important is that acid secretion can be stimulated by a lot of different factors, but if like we're trying to block it in terms of drugs, if you use something downstream like a proton pump inhibitor, that's more likely to have a bigger effect than using like an antihistamine or something. And then there's different phases they talk about. So I think it's pretty self-explanatory. Cephalic is like sensory, sight, smell, chew, taste. It's going to stimulate your autonomic nervous system, so your vagus, to increase their kind of function and increase acid production. And then gastric is the stretch of the stomach, which is going to signal that we need more acid. And it does this, it increases acid production via the vagus again, but also it can activate your local enteric submucosal reflex. And then the intestinal phase is when the duodenum gets stretched, and it also responds to decreased acidity, decreased pH, so acidity, and it inhibits your parasympathetic, so inhibiting the vagal and the local submucosal plexus. And it also starts to stimulate your endocrine secretions, like CCK and things like that, for the digestion of fat. Clinical relevance, peptic ulcer disease. So that's when the protective mechanisms of your stomach, which I talked about earlier, are overwhelmed. And usually the two most common causes are H. pylori, which is like an infection, and NSAIDs. And duodenal ulcers are way more common than gastric ulcers. And they can complicate by eroding through the wall and rupturing arteries. And the treatment is triple therapy, so PPI plus 2 antibiotics, and the common one is omeprazole plus amoxicillin plus clarithromycin. So I'd remember those 3, or any azole really, That just means it's PPI. In this case, it also means other things, but omeprazole and then amoxicillin, clarithromycin.
And also remember these specific arteries for the duodenal and gastric ulcer, because it might be a question. I think we may have had this.
Yeah.
I don't know, but someone has a duodenal ulcer and then suddenly they bleed out. What is the most likely artery that's been affected? Or it'll be something like that. So if it's a duodenal, it's most likely to rupture the gastroduodenal artery, whereas if it's the gastric, it's the splenic artery. And that's just kind of a buzzwordy thing.
Yeah.
But if you remember also the diagrams of the arteries, it makes sense as well.
And then quickly on appetite, I think it's pretty complex. What I really remembered was that ghrelin stimulates appetite. So, grr, my stomach's hungry, ghrelin, and then the others do the other things. So leptin and insulin suppress appetite and increase metabolism. Yeah. So transpyloric plane, it's like an anatomical thing that they might test you on. A lot of different things happen there. And I think being able to visualize it in some sense is probably the most helpful thing. So I included a few diagrams. There's a list. Important ones is that it's at the level of L1. And so we already talked about it earlier, but that's going to be where your SMA is. And also the second part of the duodenum, your pylorus, and a lot of the hilar, kidney, spleen, and also the termination of the spinal cord. They're the important ones. Then moving on to the small intestine, which is all about nutrient absorption, really. So the big kind of nutrients to remember is the duodenum is iron, the jejunum is folate and most other nutrients, and the ileum is vitamin B12. And then here is just kind of the layers. So you've got your mucosa, epithelium, laminal propria, muscularis mucosa, and then your submucosa, which has a plexus attached to that, and then your muscular layer, which between the two muscle layers has your myenteric plexus, and then your kind of serosa. Yeah. So the duodenum in a little bit more detail, it's got the cap, which is intraperitoneal. Then it's got the second part is where the duodenal papilla, major duodenal papilla is, which is where the bile and pancreatic secretions enter. And it's also like the junction between the foregut and midgut. And then the third part is anterior to the aorta and the IVC, down here. And then the fourth part ends at the duodenal flexure, which is supported by the ligament of Treitz, which is kind of like, I can't remember what that was. Anyway, sorry. And yeah, the second, third, fourth part are retroperitoneal. And then important functions, absorption of iron, secrete alkaline mucus and neutralize the stomach acid. And then on histology, the big buzzword is Brunner's glands, which basically, help secrete a lot of the bicarbonate mucus, which makes it an environment that activates pancreatic enzymes. So acid is for the stomach enzymes, and then a more alkaline environment is for the pancreatic enzymes. Then you go on to your jejunum, which absorption of nutrients again, folate. The features are plicae circularis, which are kind of like these little muscular bands that go around the tube. And then there's also villi and microvilli, creating a brush border on histology. And then the ileum, which is important for the absorption of B12 and bile salts. And the big buzzword here is Peyer's patches, which is specialized lymphoid tissue. So that's what this is. So a lot of immune function in the ileum. And also, I think this is a good table that summarizes some of the difference. So the jejunum, it's deeper red because there's more of a blood supply. So there's still more food in the jejunum because it goes through the jejunum and then the ileum. And the vasa recta are long, and there's fewer arcades. So basically there's more bigger vessels, so it's getting more blood. Whereas in the ileum, there's lots of tiny little vessels. So short vasa recta, lots of loops and less blood getting there though, ultimately. And so it's paler. And I think Charlotte remembered like a giraffe is the jejunum or something like that.
Sorry. Jejunum is like giraffe, so it's longer. And then it was something like ileum was an elephant, so it's about. But I just remember the giraffe one. So it's long vasa recta.
And then motility in the small intestine. So initially you have segmenting contractions. And so that's just mixing the chyme and facilitating contraction. Facilitating contact with the intestinal wall. So as you can see here. And then when most of the meal's been absorbed, it kind of transitions to a migrating myoelectric complex. So that's kind of like a coordinated movement, coordinated contraction and peristaltic movement of food, which moves the bolus through the small intestine to the large intestine, and also helps prevent bacterial overgrowth. Clinical relevance, celiac disease. So mostly affects the duodenum and therefore iron absorption. So you can get a microcytic anemia. And on histology, the features are villus atrophy, crypt hyperplasia, and increased number of lymphocytes. So if you see those words, especially crypt hyperplasia, increased number of lymphocytes, and villus atrophy, usually they'll come in that trio. Think celiac disease. And Crohn's disease can affect anywhere along the GIT, which is a form of inflammatory bowel disease, but especially affects the terminal ileum. But Charlotte will talk about that in a bit more detail. Cool. Do you want me to share?
Do you want me to share? So then I know when.
Sounds good.
Share screen. Okay. Cool. So now we're so now we've got the large bowel or the hindgut or the colon. So we'll start. So just basically you've got your large bowel, which is surrounding your small intestine in the stomach, and it absorbs any remaining nutrients and the water and then stores your food basically. So you start with your cecum and appendix, which is, they're actually part of the midgut. So if it's midgut, it's SMA, but also part of the colon is SMA. So that doesn't completely help anyway. But then it goes to ascending colon. And as Izzy said before, how it rotates between intra and retroperitoneal. So you've got cecum and appendix start intra, and then you've got ascending colon is retroperitoneal, then transverse is intra, and then descending is retro, sigmoid is intra, and then your rectum, it's like divided into thirds where it's the upper third is intraperitoneal, the middle is retro, and then the outer third is no longer related to that. And then your anal canal is not really part of the colon, but that's how it ends. And so the difference between the small intestine and the large intestine is that the large has these things called Taenia coli. So they're these long, oh my God, sorry, can you hear that pinging? Is that, there we go. And so the Taenia coli are these long bands that go along the colon, and when they contract, it creates these things called haustra. So they're these pouches, which you can see on the X-ray, and they differ from these plicae circularis in that the rings don't go totally around the colon. And then the colon, just in terms of appearance, also has these things called epiploic appendices or amental appendices, and they're just these little fatty blobs. So that's how you can also distinguish it, and it's a lot fatter than the small intestine. So the blood supply is the SMA and the IMA. So if you're just kind of thinking midgut, hindgut, and just it's further down the aorta. So from the SMA, you have, it kind of makes sense when you look at the diagram in that you have, so first of all, you've got your SMA at the top, and then it's got three branches that supply your colon. So you've first got the ileocolic, which is the ileum and the cecum and appendix, and then your right colic, which is going to be the right colon, the middle colic, which is your transverse or the middle colon. And then you move on to your IMA, which has three branches. So you have your left colon, your sigmoid, and your rectum. And the rectum is just important that the proximal rectum is from the superior rectal, but then the middle rectum is your middle rectal artery, which is not from the IMA, and also the distal rectum is not from the IMA as well. Not super important, but it helps with blood supply and drainage. But yeah, the IMA is only the proximal bit of the rectum. So in terms of just back to the physiology, so similar to the small intestine, you have these mixing contractions, but with the large, you call them haustral contractions. So they're these slow mixing contractions. So when there's matter enters the intestine, you get a stretch. the stretch activates your myenteric nerves, and then your circular muscle contracts, and so do your longitudinal, or these tenia coli, leading to the house drop. And these happen to mix it and push it along. But then you get these big mass movements, which happen less often, and it's like kind of slow, big push of the luminal contents. And as you can see in the picture, you lose your house drop, and that's created by these gastrocolic and duodenal colic reflexes, basically by the stretch. And it's when you want to make more room, and then it leads to this defecation reflex. So when you get these mass movements, the poo goes into the rectum, and then your sensory fibers go to your spinal cord, which activates these spinal reflexes, and you get, in combination with your parasympathetic nervous system and your enteric or your gut nervous system, you get contraction of the rectum, you get more mucus, and then your internal anal sphincter, so that's not voluntary, relaxes. And then you only poo when you get voluntary relaxation of the external anal sphincter. So if you choose that you don't want to defecate, then you get this thing called reverse peristalsis. So the poo goes back up further into your rectum until another mass movement, which restarts this process. And if you're at the right place and time, then you can relax your external sphincter. And this is just a good diagram that shows the steps, but it's basically written here as well. So just in terms of clinical relevance, in the same way that you vomit up blood, you can poo out blood, and the colour can give some clues to what the problem might be. So if it's bright red, then it's more likely something like further down in the GIT tract. So it's just like coating it. It might be a hemorrhoid or an anal fissure bleeding. If it's mixed in, it might be something like cancer or ulcerative colitis. If it's really dark, it might be an upper GIT problem. And if it's just invisible, like that's called a fecal occult blood test, which they do as a screening thing for bowel cancer. But basically, if it's bright, it's further down, it's closer to the rectum. If it's dark, it's an upper GIT problem. So just a few little conditions. So we've got appendicitis, which is what we talked about at the start. So you've got this acute inflammation of the appendix. Usually it's caused by a little, this thing called a fecal lift, but it's just a hard little blob of poo that gets stuck in the appendix and blocks it off. And then so you get this vague pain as it's irritating your visceral peritoneum in the central area. And then when it gets worse and you irritate the parietal peritoneum, which is the localized pain, it then moves into the right iliac fossa. And then inflammatory bowel disease, just as it's not, I don't know if they'd actually ask a question on it, but you learn more about it next year as well. Just basically this inflammation of the bowel contributed by genetics and your environment and things. And you get basically diarrhea and abdo pain. And there's two types in that you have ulcerative colitis and Crohn's disease. So ulcerative is just the mucosa only, and it's this continuous inflammation starting from the rectum. So it starts here and moves up, and it's all one continuous line. And just as you're more likely to get bloody mucousy diarrhea because it's closer to the, like it's affecting the bit just before you defecate. Whereas Crohn's is these skip lesions, which can occur anywhere in the tract, in the GIT tract, and you get this cobblestone appearance. Yeah, when we were taught about this, I still use it to remember. Crohn's is like a crow, so it hops, and so it skips bits. But yeah, that's just a quick overview. And then hemorrhoids. So Izzy kind of talked about this with portal hypertension, but basically you have these normal venous cushions in your anal canal, and then when they, due to extra pressure or constipation or unknown factors, they get enlarged, and basically these extra blood in it. And so they can bleed or you can get pain. And the most important thing is if they're internal or external. So if they're above this dentate line, there's a slide coming, then if they're internal, and internal ones are going to be not painful because that's a visceral innervation, whereas external ones are somatic innervation, so they're going to be painful. And then you also have anal fissures, which are just cracks or tears in the anal canal due to like constipation or trauma or pregnancy, and that's just pain when you defecate, and bright red blood when you on your toilet paper. So this is just quickly over the pectinate or dentate line. So it's where it transitions from the endoderm of the gut tube to the external ectoderm. And so the main important thing is that above it is pain, is painless, below is pain, based on your visceral versus somatic innervation. And then also they have different lymphatic drainage, so it's internal versus inguinal nodes, and then the different arterial supply. So above the dentate line is still your IMA supply, whereas you have the inferior rectal artery from the internal iliac below. Yeah, but the main thing that I would remember is painful and painless, and if it's internal and external. And this is just a quick little clinical relevance on the buzzwords of the bugs and how they lead to diarrhea kind of thing. And so just, it keeps coming up. You just got to try your best. But so norovirus and rotavirus are the kind of your gastro bugs, and noro is adults and rotavirus is kids. And the way Izzy told me to remember is rotavirus is like Rugrats, like a little kids TV show, so that's kids, or people who have been around kids, so like if they've been in the kindergarten. Then your Campylobacter is the most common. Listeria is your soft cheeses, your cantaloupe, your pregnancy issue in pregnancy. C. diff is after you've had antibiotics. E. coli is travellers, Staph aureus. I don't know much about Staph aureus diarrhea, to be honest. Salmonella is like overseas kind of things. Salmonella enteritidis, one is your chicken. H. pylori is your peptic ulcer disease. Cholera causes your white rice water diarrhea. Bacillus is rice, is wet from rice. Shigella causes dysentery diarrhea, so just bloody, and it's kind of a sexual transmission, can be related to that. And then Clostridium botulinum is canned foods and paralysis, if you think like Botox paralysis. But they're just kind of buzzwordy things. So moving on to the organs, which is a bit more interesting. So your spleen is an intraperitoneal organ. It's in your left upper quadrant, and it's connected by your gastrosplenic ligament and your splenorenal ligament. It's supplied by the splenic artery and drained from the celiac trunk and drained by the splenic vein joining the IM. And the most important thing is that the splenic vein joins the IMV to form the portal vein with the SMV. And so its function is it's kind of a lymphatic organ. So you've got this red pulp, which is most of it, which filters your red blood cells, and then white pulp, which has all your immune cells to fight infections. And so it holds a lot of platelets to maintain equilibrium. And then when you have, if you get your spleen removed, it can be an issue with infections because you lack these your immune cells, so your increased risk of encapsulated bacteria because you don't have like antibodies from B cells, so you need to be vaccinated. So your pancreas, this is the left upper quadrant posterior to the stomach, and it's secondarily retroperitoneal except for the tail, and then you remember it like the tail tickles the spleen, and the spleen is intraperitoneal, so that's intraperitoneal. And it's got your head, your neck, your body, your tail, and your unsnake processes hidden in here. And it's just kind of important anatomical relationship that your SMA and SMB kind of run through it. And it's got exocrine and endocrine function. So your exocrine is secreting stuff into the ducts, and that's your enzyme aid digestion, where its endocrine function is things, hormones into the blood. So that's your insulin and glucagon, which I'll talk about in a second. So here your endocrine function is your islets of Langerhans. So that's your things in the middle. So you have your beta cells with insulin and your alpha cells with glucagon. They're the most important ones, and they're good. They're important for controlling your blood sugar. And then your exocrine function is kind of mainly your bicarb and your digestive enzymes. So when you have acidic stimulus from your food, it leads to secretin being released, which I'll talk about more specifically later. But the secretin leads to your pancreatic ductal cells releasing this bicarb to protect from the acid. Whereas if you've got fatty food, then you need your enzymes to digest it. So this CCK is released, which triggers the acinized cells to release these digestive enzymes. And the first one is trypsinogen, which is activated by these brush border cells in the called enterokinase. And that is transformed to trypsin, which then can activate all the other zymogens, so that your inactive enzyme that can lead to phospholipase, amylase, lipase, to digest your fats. So just as a clinical relevance, you have your pancreatitis, which is just auto-digestion from the enzymes, leading to inflammation and bleeding and death, cell death. And you get this epigastric pain, and it radiates to the back. And you guys remember why it would radiate to the back? I can't see the chat. I don't know how to do this. You can say it, or...
No one's replied yet. I'll let you know if they do.
I can see it. I've got it up now.
Okay.
Anyone know what I want to say? Okay, so if it's radiating to the back, then it's going to be secondarily retroperitoneal because it's at the back. So that's kind of, yeah, that's right. And you can get nausea and vomiting with it. And the causes are the acronym I get smashed, which I'm sure you've heard about, which is really long, but the most important thing that it's gallstones and alcohol are the main two causes. And then you diagnose it, you get these raised serum lipase and amylase because they're the digestive enzymes, and you treat it with fluids and pain management, basically, and you hope it goes away. And then head of pancreas cancer is like your buzzword of the painless jaundice with the positive Culver's sign, which I can never say. And because that's, you get jaundice from like the mass blocking your bile ducts, and then so it leaks out. Yes. Okay, so just a few pancreatic other clinical relevance things. So you've got cystic fibrosis, so you have defective pancreatic secretions because you have this defect in your chlorine pump, so they're kind of thick, and you get this exocrine pancreatic deficiency, so you don't digest your food, leading to like malnutrition. Steatorrhea is just like floaty poos, because fatty poos, because you haven't digested your fat. You can get respiratory failure because it affects your secretions in your lungs too. And then you have diabetes, where you have type 1 is your autoimmune destruction of your insulin endocrine cells, and that's more your children, whereas you have type 2, which is kind of related to your lifestyle things like being overweight. And yeah, so you get this relative insulin deficiency from impaired beta cell function. But yeah. So your liver is your right upper quadrant, and it's intraperitoneal, and it's all covered by your visceral peritoneum except for the bare area at the top. And it's got your functional, so it's divided into functional lobes and anatomical lobes. And just the anatomical is just your right and left, whereas your functional is based on the biliary tree. There's a big complicated diagram, but I don't think it's super important. And then in the middle, you have your porta hepatis, which is your bile duct, portal vein, and hepatic artery. And the liver functions to filter nutrients. So everything from the GIT that's drained into the portal venous system goes to the liver through the portal vein. And then it also is important in metabolism of like sugar, fats, drugs. Synthesizes a lot of proteins, so like your clotting factors, albumin, bile, cholesterol, immune things, and it helps you excrete bilirubin by conjugating it, and also ammonia by converting it to urea. And that's just a little summary diagram. So the blood supply, it's mostly supplied by the hepatic portal vein. So that's all your SMA, SMV, and splenic vein joining together and draining into the liver. And this is partly deoxygenated because it's a vein, but it still has lots of nutrients from the small intestine. And then it goes to the liver sinusoids, and for the liver to like detoxify it. So yeah, the hepatic vein is formed by the SMV and the splenic vein.
For that tomorrow.
Sorry? Was that a question?
I think someone had their microphone on by accident.
Oh, no worries. Hello. And then the remaining 25% is your hepatic artery. So that's just kind of supplying the bile ducts. So your histology of the liver is that you have, it's arranged into, the hepatocytes are arranged into liver lobules, which is like a functional unit, and it's your hexagon. So you have, at each corner you have a portal triad with your arterial hepatic portal vein and your hepatic bile duct, and these all drain into this central vein by, like, it drains through and mix in the sinusoids, which is through here, to perform the gut functions, and then they drain to the central vein and ultimately to the hepatic vein to the inferior vena cava. And then you have lining the sinusoid, you have also your Kupffer and stellate cells, and the Kupffer cells are just like liver macrophages, and the stellate cells are important because they produce fibrosis when you get liver cirrhosis. So your LF liver function tests, which are kind of important and help you work out what might be going wrong, and they're kind of weird because they don't tell you directly how the liver is functioning, rather they tell you damage. So your main ones are your liver enzyme. Sorry, 1 second. Go away. And then, so you have your main ones are your ALT and AST, and they're going to be released when you have a hepatocellular damage. So something like viral hepatitis, autoimmune hepatitis, or liver disease. And then you have your GGT and ALP, which is going to be your obstructive or cholestatic, so your gallbladder picture. And I remember this as gallbladder and pancreatitis with GMP, and that's how I still remember it. And then you also have other markers of synthetic function, so that's like your proteins. So you measure albumin, you can measure your INR, which is your clotting times, because it produces clotting factors. And then you can also measure bilirubin, and that's kind of telling you the function, if it's being conjugated by the liver or not. So if you've got high unconjugated bilirubin, then it's going to be something before the liver. So you've got extra bilirubin that the liver can't keep up with, so mostly like hemolysis. Whereas if it's conjugated, then you might have, it's after the liver, so the liver is still working. So it's going to be a biliary thing, where if it's mixed, then because the liver can't function, plus it's being released, you get a mixed conjugated and unconjugated. So then that's a liver problem. But I think it comes up. And then there's specific ratios, which apparently I don't think that's super reliable. But like if it's the ALT is really, really high, then it's a serious liver disease. So like something like a Panadol overdose. Whereas if the AST is higher than the ALT, then it's maybe like alcoholic liver disease. And then just as a way to remember it, stubbies over liver. So your S is greater than your L when it's alcoholic. Because they're, yeah. So Izzy kind of already talked about this, but portal hypertension is kind of related to the liver blood supply. So when you get obstruction from the blood flow to the liver through either a clot or because of liver death, this can lead to a higher blood pressure in your portal system. And this forces blood back through these anastomoses where the portal venous system connects with the normal systemic venous system. And then these dilate and you get things called varices. So your varices, like your main one are your esophageal varices, and they can dilate and bleed. And these are just the connections. So your esophageal varices are between your gastric vein, and then which is your portal system, and then your azygos system, which is your systemic venous system, is the main example. And you can also get splenomegaly and ascites from this extra pressure, so fluid leaks out. And just other little liver conditions. So you have non-alcoholic fatty liver disease. So you get, so it's not caused by alcohol drinking, but you get build up of fat in your liver cells, which then becomes inflamed and then your cells die. And it's the same process with alcoholic liver disease, but it's just caused by drinking too much alcohol for a long period of time, leading to build up of fat, but not super important. And then hepatitis so that's inflammation of the liver, basically. And it's the main causes. So you've got Hep A, B, C, and D. And I just kind of remember that, oh, sorry, that's meant to be E, not D there. So A and E are on either side of the alphabet. So they're the fecal oral, because they're the two ends of your GIT. And then the ones in the middle are like blood and bodily fluids. And B is the one that is an STI, whereas C is more associated with IV drug use and is the chronic one. So C for chronic is how I remember, and you just get things like you're really tired, you lose your appetite, you have right upper quadrant pain because that's where the liver is, you can get jaundice, and this is just a little mnemonic to remember it, but yeah, you can read that. And then I don't know how much you guys do the liver serology, but it came up and was not super explained to us. I think we just got a YouTube video. But basically your surface antigen, if the Hep B surface antigen is the marker of infection, and if you have an antibody to that, then that means you've caught up the infection. But, yeah. So moving on to the gallbladder. So this is an organ under the liver. So in your right upper quadrant has a fundus, a body, the infundibulum, which is kind of important because Hartmann's pouch is there, and that's where gallstones are most likely to be stuck. And it stores and concentrates bile from the liver. And then so when you get CCK release from the digestive tract, then this kind of stimulates the gallbladder to secrete the bile. And then you have the cystic duct, which joins the common hepatic duct to form the common bile duct, which joins this pancreatic duct and drains into the duodenum via the ampulla of Barth. So gallstones is kind of the main clinical relevance here. So you have your four main types. So cholelithiasis is simply just gallstones in the gallbladder, and mostly they're cholesterol stones. So you get excess cholesterol, which precipitates, causing stones. And then you have pigment stones, which are made of bilirubin. So that's from like too much hemolysis. And your main risk factors for this are your multiple F. So if they're fat, they're 40, they're female, they're fertile, which is just related to estrogen, or they're fair. And this can be asymptomatic. So lots of people just have incidental gallstones, but you get issues when you get cholelithiasis or cholecystitis. So cholelithiasis just means stones in the bile ducts, and that can cause obstruction. And this is when you get your jaundice and your typical colic. So that's the pain that comes and goes. And whereas your cholecystitis is inflammation of the gallbladder, you don't necessarily have obstruction, but you just get this infection. And that's when you get this positive Murphy sign. So in your GIT exam, when you sweep up across to the liver and then you get them to inspire and their breath catches, that's your positive Murphy sign and usually indicates cholecystitis. And the main treatment is you remove the gallbladder. And then ascending cholangitis is a further complication where you get inflammation of the whole biliary tree. So usually you have cholelithiasis leading to your bile stasis and obstruction, and then infection enters from the bowel. And you get this thing called Charcot's triad, which is jaundice, right upper quadrant pain, and fever is the distinguishing factor. So biliary tree, which we've kind of touched on, but you have ducts from the liver, the gallbladder, and the pancreas all joined together to enter the duodenum. So you have your bile from your gallbladder, which forms the cystic duct, which joins your common hepatic duct from the liver, draining through to where it joins the pancreatic duct from the pancreas, and then that enters through the ampulla of Barth at the second part of the duodenum, just as an anatomical point. And then so your bile, which is synthesized and secreted by the liver, and then it's stored and concentrated in the gallbladder. So when you eat a meal, it stimulates the gallbladder to contract and empty this bile into the duodenum. And your bile is mostly made of water, but it's also got your bile salts, which is important in digestion of fat. So the bile salts surround these emulsion droplets created by the GIT tract, and then it allows the pancreatic lipase from your pancreatic secretions to enter in and further break it down. So then your fats can diffuse across, as seen in this picture. And so we've got cholesterol, lecithin, or phospholipids, which combines with the bile salt. And then you have electrolytes and water to neutralize the acidic contents, and bile, which makes it green. The pigments, which makes it green. And then most of it is reabsorbed back, and of the bile salts is reabsorbed back, and they can be recycled. So this is the regulation of the bile secretion. So what we were talking about before with your secretin and CCK. So when you have acid and fat in your duodenum, it stimulates these enteroendocrine cells lining your duodenum to release secretin and CCK, which enter the bloodstream. So your secretin, they call like nature's antacid, because that leads to the production of bicarb from your pancreatic ductal cells, and also stimulates the liver to produce bile. Whereas the CCK is in response to fats. So that's when you want your gallbladder to contract and release bile. And you also want enzymes from your acinar cells in the pancreas so they can digest the fats. And it relaxes the sphincter of body so it can enter in as well. And I find this diagram really helpful. Step through the process. Does that make sense? So your bilirubin metabolism is related to your jaundice, and red cell based bilirubin is from red blood cell metabolism. So you have your hemoglobin, which is broken down into your heme and your globin, and then this heme, which is made of iron and biliverdin, and that's what makes it green. And then your biliverdin is converted to unconjugated bilirubin, which then goes to the liver and is conjugated by the liver to conjugated bilirubin so that it's water soluble. And that's what goes into your bile. And then this is converted to urobilinogen by your intestinal bacteria. And it's secreted a little bit in the urine to urobilin, which makes it yellow. So if you've got dark urine, then you've got more conjugated bilirubin. But most of it is excreted in your feces, and it's converted to this stercobilin, which is brown. So if you've got pale stools, then it's from a lack of stercobilin because there might be an obstruction which is stopping it from being broken down. So jaundice is from when you get build-up of this bilirubin in the blood, and you get yellowing of the skin and the sclera in your eyes. But it's only clinically evident when you have twice the amount of bilirubin. And that's just kind of, those two diagrams kind of summarize the process. So basically the liver conjugates your bilirubin so that you can excrete it in your poo. So jaundice, you have prehepatic, intrahepatic, and posthepatic. So your prehepatic is before the liver, and it's going to be unconjugated because it's just extra breakdown and it hasn't reached the liver yet. And so this is usually from hemolysis, so death of red blood cells. And it's, so that can increase the risk of pigmented gallstones as well. And then you have intrahepatic jaundice, which is a mixed type of excess bilirubin. So you have conjugated and unconjugated. And this can be from like cell death, inflammation of the liver. And the reason you get both is because you lose the ability to conjugate, plus it leaks out. So you get the both, and that leads to dark urine because you've got the more of the conjugated bilirubin being metabolized, and you can get an itch as well. Whereas posthepatic, so that's after the liver, so that's going to be your obstructive picture, so high ALP and GGT, and that's from like gallstones or pancreatic cancer or cholangiocarcinoma. And that leads to your pale stools because it can't be excreted because it's being blocked. So it's building up in the blood but can't go out through your digestive tract. And you can also get the dark urine. And this is just a good summary table, I think, of the main causes. So prehepatic is hemolysis, it's unconjugated, whereas intrahepatic is defective conjugation and abnormal secretion, so it's mixed, whereas posthepatic is it's conjugated because it's obstruction afterwards. And only here you get the pale stools, whereas in the intra and post you get the dark urine. So moving on to pharmacology. Does anyone have any questions so far? Any questions? No? Cool. So I think Izzy's going through constipation.
Yeah. So pretty briefly, I think kind of drugs are kind of the thing you just have to sit down and go through. But yeah, basically with constipation, the whole idea is to try and get like your fecal matter out. So laxatives are going to increase the speed of food passing through your digestive tract, and then you can also use fecal softeners as well. So there's different types, and actually knowing an example of each type is quite important. So bulk laxative, Metamucil, and basically it's just a poorly digested compound which retains water in the lumen, and then that's going to promote peristalsis, and it can affect pharmacokinetics of some drugs. You've also got osmotic laxatives, so that's like lactulose and Movicol, which is also PEG, and that was like one of the only laxatives I really remembered, because PEG, polyethylene glycol, is indicated for bowel prep before surgery, and these drugs, they're basically really salty or really sugary, and just via osmosis draw water into the gut, and that makes your fecal contents go through fast, but they're kind of avoid them in renal impairment, or they can cause cardiac impairment. There's also stimulant laxatives, so that's Senna. So I remember S for stimulant, S for Senna. And that's kind of increasing peristalsis by activating your enteric nervous system, and also increasing secretions. And potentially there might be some concern that it can cause lazy bowel long term, but I don't think that's that important. And then for fecal softeners, the main one is Coloxil, and often Senna and Coloxil are used in combination in like elderly people. So Senna being the stimulant and Coloxil being the fecal softener. And it's like surfactant, so it reduces water tension and softens feces, and also has a weak laxative effect. And it's really useful when straining should be avoided. So if the question was a pregnant woman had constipation or something, then that's kind of the Coloxil example. And it's also first line for children because it's kind of like the least impact on your digestive system. That's my understanding anyway. And then dopamine receptor antagonists, metoclopramide and domperidone can also be used, and they're also used as antiemetics. So that's why they're a bit smaller, and they stimulate D2 receptors, inhibit cholinergic. I better check that actually. Inhibit cholinergic smooth muscle activation and enhance gastric activity. That's constipation drugs in a nutshell. Can you change the slide, Shah? And then in terms of like the order of them, the first line basically for everything is always lifestyle modification. So exercise, fluid intake, and fiber. They're kind of big. So if that's like an option in the question, it's probably right. And then you've got your bulk laxatives, softeners, osmotic laxative, stimulant. And then you can also do suppository enemas, which is like injected up the rectum, and chorionic lavage, which is kind of where, again, you go up through the rectum and kind of try and wash it out, I think. Yeah. But they're more for like emergency acute management.
Sorry, we just had a question. I just got a question saying why you don't get pale stools in pre and intrahepatic jaundice. So you only get them in the post-hepatic, by my understanding, is because post-hepatic is obstruction. So the bilirubin metabolites can't actually get into the GIT tract, because that's how you get pale stools, from having lack of the bilirubin metabolites in your feces. Does that make sense? I don't know how to.
Yeah.
So if it's obstructed in post-hepatic, then you don't get the metabolites into your GIT they don't go into the duodenum, so then you don't poo it out.
If you kind of imagine like the biliary tree, it's like kinked basically. It's stopping the passage of the bile and the bilirubin into the GIT. And the bile pigment is like, where the has the bilirubin breakdown stuff, which is the colour. Anyway, yeah.
Sorry. Yeah, we got it. Thank you. Oh, are you finished with this slide?
Yeah.
Okay, so with diarrhea, so usually it's kind of just supportive, and you rehydrate them, maybe give them analgesia. But if they need it, you can give an antidiarrheal, and usually this is an opioid like loperamide, and they're an agonist at the mu-opioid receptors, and this one's important because the loperamide does not cross the blood-brain barrier, and it's selective for the GIT tract. So you get less of the myenteric activity, leading to less motility, peristalsis, secretions, and so it's kind of, you're making the most of an adverse effect of the opioids. And so, but you can also get like nausea, pain, abdominal pain, platus, and you mainly use it in traveler's diarrhea. But you don't want to use this if there's bacterial diarrhea, because then they can't excrete the bug. And you don't use it in inflammatory bowel disease, because it can increase the risk of toxic megacolon. But and then maybe we'll use antibiotics, but usually it's a viral. It's usually self-limiting, so you don't need antibiotics.
And then I just chucked a quick slide in about vomiting, because there's a lot of antiemetic drugs, which we'll go through. But basically, it's a complex pathophysiology, and there's two main parts. So the chemoreceptor trigger zone, which is located in the medulla, the area postrema, and that lacks a effective blood-brain barrier. So it can be sensitive to drugs. So like chemotherapy, often a side effect is really bad nausea, and that's often related to this area of the brain. And then there's also a vomiting center as well, which is not really a discrete brain area, but it's more like a combination of areas. And you can see from this diagram that there's a lot of contributing factors. So yeah, there's a lot of causes. There's heaps of different neurotransmitters involved. So different like acetylcholine, histamine, serotonin, dopamine. And that basically means that there's a lot of different ways we can target it with drugs. That's all I wanted to kind of highlight with that.
Cool. So your antiemetics. So as Izzy already, the metoclopramide and domperidone, or your dopamine 2 receptor antagonists, which are also used in constipation. So they block these D2 receptors in this chemoreceptor trigger zone, and to reduce nausea and vomiting. And they can also be used to facilitate gastric emptying. So in your constipation, they can cause lethargy, dizziness, confusion, diarrhea. But metoclopramide is contraindicated in Parkinson's because they've already got a dopamine deficiency. So that's just kind of a buzzwordy thing. And your 5-HT3 receptor antagonist, or your ondansetron, is your first line. So this is like the most commonly used one in hospitals. These receptors are in the chemoreceptor trigger zone as well, and also in the GIT. So it's got peripheral and central effects. Side effects is you get constipation, also headache and dizziness, and it's mostly used in chemotherapy-induced nausea and vomiting, or post-operative nausea and vomiting. Another one is you can have histamine antagonists, so specifically H1, because they're in the area postrema. And they also have weak antimuscarinic effects, which is also contributes to the efficacy, but also leads to your side effects. So your blurred vision, your urinary retention, dry mouth. And they're mostly used in motion sickness or morning sickness, but will cause sedation. So your antimuscarinic is your main example is the hyphosine or quells. So this is for motion sickness. Quells is, I used to have to take them, so I found that helped me remember for motion sickness. And they're really long acting, so you can take them before travel and they work as prophylaxis. And they're non-selective antimuscarinic with effects in the vestibular nuclei and the vomiting center in the brain. But again, your side effects are these anticholinergic effects. So they decrease your parasympathetic nervous system. So you're going to get less salivation, urinary retention. And then the last one is, these are kind of a new drug, this NK1 receptor antagonist, or aprepitant. They're newer, and it works by this substance P, which acts in the GIT and the central nervous system. And they can be used in your chemotherapy, nausea and vomiting, motion sickness, alcohol, but there's drug interactions because it inhibits this liver enzyme, which is important in liver metabolism of a lot of drugs. Cool, so just some clinical skill things. Do you want to do this, Izzy? So Murphy's sign. Does anyone want to offer what this is and what would be the cause if it was positive?
Yeah, these are just like buzzwords that come up and they're good to know what they mean.
Yeah. So they're in your GIT exam, which you'll just rattle off as, yeah. Any takers? Oh, sorry, I did not mean to do that.
Or any of them, Cavieres.
Yeah, just
you can
if
say
you know one,
you
just
know.
go for it.
Ray Turners, Cullens, McBurneys, Robsons.
Okay. Should we just go through them?
Yeah, sure.
So your Murphy's sign is the one when you are feeling for the liver and you get them to breathe in when you're in the upper quadrant and they get pain, and that's in your cholecystitis. And then the Cavieres sign is when you can feel the gallbladder and you have mild pain with jaundice, and that's buzzword is head of pancreas tumour. And then your Gray Turners and Cullens are bruising from pancreatitis. They're kind of rare though. And I remember that Cullens is central, C for central, so it's around the umbilicus, whereas the Gray Turners is on the sides. And then related to your appendicitis, you have McBurney's and Rosbing's. So McBurney's is actually where the appendix is in your right lower quadrant, where the appendix is, whereas your Rosbing's is a sign of the cross tenderness. So it's on the other side. So when you press in and then when you release, there's more pain. Does that make sense? Any questions?
Well, we might just finish with a few abdo pain patterns, and then we've also included a lot of questions, but the answers are there, so you can go through those in your own time. But in terms of abdo pain patterns, colic is like when pain comes and goes, and usually it's due to like a blocking of a pipe. So that can be like your gut tube, or it can also be like a ureter or something like that. Usually described as like a 10 out of 10 grabbing pain. And so if it's central, then it's more likely to be your bowel. Large bowel obstructions, the like contractions are less frequent. So the pain comes like every 10 to 15 minutes. And then small bowel obstruction, the pain is every 2 to 3 minutes. Biliary colic is not really a true colic because the pain is constant, and it's in the right upper quadrant. Usually there's like a constant background pain and then bursts of more severe pain on top of it. So it's right upper quadrant or epigastric as well. And they might have a history of having similar episodes in the past. Worse after a fatty meal, but can be like unpredictable a little bit, and can be associated with nausea and vomiting. As Charlotte mentioned before, the risk factors are female, fat, 40, fair, fertile, and often indicate a gallbladder pathology. So it could be a stone or inflammation. And then pain in the epigastrium, that's more so if you kind of visualize back to the diagram we're going through, what structures are there. So you've got your pancreas. So thinking pancreatic disease, other features of that is that the pain would radiate to the back, relieved by tenting. So that's like when you lean forwards, that posture relieves pancreatic pain, and there might be associated vomiting, and it can be considered a steady pain. And then another pain that's located in the epigastrium can be peptic ulcer disease, which can be a dull burning pain, and it's also associated with a point sign. So patients are able to point like it hurts here, rather than just being like my stomach hurts. It's kind of more like this is where it really hurts, and it might be relieved by food and then worsened. And then appendicitis pain, we've gone through, moving from the central vague pain because of visceral referral of pain to a sharp pain in the right iliac fossa. And then peritonitis is when there's inflammation of your peritoneal cavity, your peritoneum, and that is like really severe sudden onset pain because you're getting somatic innervation to the parietal peritoneum, and it's relieved. The patient is really rigid, lying still, and guarding of the abdomen are kind of the words associated with that. There's also diaphragmatic pain. So that's pain that radiates to the shoulder, and it's because there's gas under the diaphragm which irritates the phrenic nerve. So it'll radiate to the shoulder due to like a ruptured viscus. So that might occur like a perforated ulcer, perforated gastric ulcer or something like that. And then you've also just got abdo wall pain. So that's going to be more localized if it's in like the muscle layers, and not relieved by holding really still. And that's going to be, more caused by trauma, surgical intervention, or a hernia or something like that. And then we've got a bunch of questions. But do you guys have any questions after that? If not, then I think we're done and dusted.
Yep. Any questions? Okay. Well, I think we'll put these slides somewhere available, and then you guys can just go through the questions.
Yeah, sounds good. All right. I think hopefully they should already be. I did upload them, so hopefully you should have access to them.
Awesome.
But, yeah. I think the formatting died because I'm so technologically illiterate. But anyway.
Okay, well, good luck with your exams.
Yeah. Feel free to message if you have any questions or anything. But
yeah, no worries. Yeah.
Cool. All right.
Hopefully that was okay. Not too boring. Bye.
Bye.